Different sorts of corneal ulcerations can occur. It can be of an infective origin. Even a lot of traumatic states can result in the corneal ulcerations. So basically, when we are discussing the corneal ulcerations, the keratitis or the infections of the cornea, they go side by side with the ulcerations. Sometimes these two conditions are coupled together in the keratopathy, and in other cases, they can occur individually in an individual. For example, keratopathy that just includes the infections of the cornea can occur without the occurrence of the ulceration. Vice versa, we can have the ulcerations which are not linked to the infectious state of the cornea. So these two terminologies should be kept along or should be discussed in two distinct statuses. For example, we should know that the infections can result in an ulceration because it's just a complication. Over here in this lecture, we are going to discuss the non-ulcerative keratitis conditions. That means that we're going to discuss the infectious states of the cornea, which will not usually complicate in an ulcerative condition. Of course, if the condition prevails and if it is a debilitating condition, or if the individual is immunosuppressed or immunocompromised, even these conditions can sometimes complicate. It's not a hard and fast rule, but generally these conditions occur individually and they are not complicated by an ulceration of the cornea, which occurs. So having the background knowledge regarding the applied anatomy of the cornea is again very important. We'll be discussing the layers of the cornea that are involved in these kind of keratitis conditions. In non-ulcerative keratitic conditions, the epithelium usually is just involved, and we all know that the corneal epithelium regards the stratified squamous kind of epithelium over here. After that, we have a layer of columnar epithelium which has tight junctions, and that is how it is basically a tough kind of epithelium which the cornea has. Usually, it is not possible to invade this epithelium and involve the stromal layer until and unless the infectious states are virulent enough to cause damage to the substantia propria, or even the endothelium or the Descemet's membrane can be involved in quite complicated cases. So we have the non-ulcerative superficial keratitis. As the name is indicating, it's a superficial sort of keratitis, and superficial is basically giving way to the meaning that it's just involving the epithelium. It's not involving the substantia propria of the cornea over here. The causes which can result in a non-ulcerative kind of superficial keratitis can be the viral causes, which basically can be the herpes simplex virus, the herpes zoster virus, the chlamydial infections can even result in a non-ulcerative kind of superficial keratitis. We can have the toxic kind of keratitis or even the trophic kind of keratitises that we have discussed. Trophic keratitises were basically resulting due to the neurotrophic kind of pathologies that basically resolves when there is any damage that is occurring to the neurons, and that results in the ulcerative kind of keratitis or even the exposure keratitis in these cases. So these are the multiple causes that can contribute towards the development of non-ulcerative kind of keratitis in these patients. Again, when you will come across these patients in your outpatient departments, they would come up with the quite similar history of redness in the eyes, tearing, excessive lacrimation, foreign body sensations. So these would be the kind of complaints that these patients would come up with. When you'd ask the patient to sit against you with a slit lamp and you would examine the patient in detail, you would find that there are these particular spots which are known as the KP spots, and they can be found in the conditions of the keratitis. So they're not associated in any way with the formation or the building up of the ulcerous states in the cornea, but it's just the infections of the cornea, and only you can note the cloudiness of the cornea in these cases. Even in a lot of cases which are complicated, they would complain of the decrease in the visual acuity. So this is one of the major complaints as well over here. The causes over here would include the conditions of varied etiology. Basically, it is of two types, and the inflammatory reactions are confined just to the epithelium, as I was already emphasizing on the fact that it's just a superficial condition. We're just talking about the most superficial infections over here. So here, the infections would be just confined to the epithelium, and it would not really reach the stromal layer or even the endothelium or the Descemet's membrane of the cornea. The reactions are confined to the superficial stromal lamella over here. So again, there are some of the virulent states of, or even the immunosuppressed states of the individual himself or herself can aggravate the conditions and can aggravate the situations in a lot of cases. Also, sometimes they're restricted to the Bowman's membrane. So it's depending and it's a variance that you would see when you're checking out the patients, and when you're just examining the patients, you would just observe that some of the infections would be including just the epithelium, then some of the infections can involve the stromal layer, and in some of the cases, the Bowman's capsule can be reached. But other than that, of course, these infections cannot travel all the way down to the Descemet's membrane. Remembering the features or remembering the layers of the histology of the cornea is again very important to have a better understanding of these infections. When I say superficial, we are talking about the layers up to the Bowman's capsule, and it's not deeper than that. Deeper than that, we have the stromal layer, and then we have the Descemet's layer and the endothelium. So these superficial infections do not reach these deeper layers of the cornea, which can result in a subsequent perforation or subsequent ulcerations of the cornea over here. Then we have the diffuse superficial keratitis. So some of the conditions over here in which the infections are superficial and they're just involving the uppermost layers of the cornea, they can be of a diffuse type. You won't see any sorts of ulcerations in these kind of keratitic conditions, and neither you would see any kind of perforations in these conditions. It would be just a diffuse cloudiness that you would observe in these patients. The acute diffuse superficial keratitis is one of the conditions. So depending upon the time duration that it takes for the keratitis to develop, or that it takes for the inflammatory conditions to develop in an individual, would categorize these conditions into an acute state, depending upon if it is occurring in a period of less than 24 hours, and a chronic state also develops in the other individuals. The etiology of an acute diffuse superficial keratitis would include mostly it is of an infective origin. They're usually linked with the other infections. Sometimes, for example, states of tuberculous infections. If the patient is suffering from syphilis, if the patient is suffering from tuberculous infections, or either the patient is suffering from malaria. So all of these infections can even result in a state of diffuse keratitis that you would observe when you examine the eyes of the individual. Usually these patients are the diagnosed cases of malaria or TB, and they are already on the regimens that are particular to that treatment. So you would basically examine the patient in detail, and depending upon the condition of the cornea, you would suggest the kind of the treatment that should be given to such patients. The clinical features would be of a faint diffuse epithelial edema that you would notice in these patients. Usually there is a gray pernicious appearance and just the erosions. You have to distinguish erosions from ulcerations. Erosions are not a breach in the epithelium. They are just subsequently related to these most superficial layers of the epithelium, and so that's why they do not really amount to an ulceration in these cases. Once you have diagnosed these cases to be suffering from any other systemic illness, and then finally they are resulting in a state of keratitis, you would make a treatment plan for these cases. Obviously, we have the conventional therapy in our mind that basically includes the instilling of steroid drops in these patients, as well as we give cycloplegics to these patients. That is, the atropine is usually prescribed to these patients. So the antibiotic drops can be also given as a specific therapy, like tobramycin and gentamicin. So these are the kind of the topical treatments that you would advise to the patients. The systemic therapies will be according to the systemic disease that they are suffering from. So this is the kind of the management you would give to these patients who are suffering from a diffuse kind of keratitis. Then on the other hand, we have a chronic diffuse superficial keratitis. Over here, it's usually seen in the rosacea patients. So we already considered the fact that it's basically a condition which is an autoimmune disorder. Usually it can result in trophic ulceritis, or even it can result in the marginal kind of ulceritis in a lot of patients, but sometimes it only results in a diffuse kind of superficial keratitis in a lot of patients. Usually the patients would present to you with a malar rash, that is the rash on the cheeks, as well as a rash on the nasal bridge. So this would be the particular clinical picture in patients of the acne rosacea. Then there would be skin lesions that are associated with it. The treatment over here would be also depending upon the underlying condition. If the patient is having the acne rosacea, or he or she is suffering from this condition, you would first of all treat this condition, and that is going to subsequently relate to the treatment of the cornea. Obviously, you would instill the antibiotic drops to stop any superimposed bacterial infections in these cases, as well as you can instill the steroid drops coupled up with the cycloplegic therapy in these patients. Now, it is also seen in conditions, for example, flictanulosis. That is, again, one of the autoimmune disorder. It's also associated with bulbar conjunctivitis and follicular conjunctivitis in patients. And then we have it is sometimes associated with the pannus formation. Pannus, we already considered that it's basically an infectious state of the cornea, which is associated with the development of hypopyon, the collection of the pussy discharge in the anterior chamber is basically known as, or it is accounted as to be, the pannus formation in these patients. So these are the conditions that can be coupled up with the development of a chronic diffuse keratitis in these patients. The management plan would obviously include to treat the underlying causes, whatever the cause is in these patients of diffuse superficial keratitis. So this, sometimes we have the punctate keratitis. I already mentioned the presence of KP spots, and they are basically quite visible over here. You can observe that there is a cloudiness of the cornea. Its transparency is affected over here in this kind of punctate sort of a keratitis, and there are these whitish spots that can be observed on the cornea. This examination is usually done on a slit lamp, and a slit lamp really enhances the findings of the keratitis in the patients. So whenever you suspect that this patient is suffering from some sort of a corneal disorder, the patient presents to you with a history of a decrease in the visual acuity, you are going to make him sit on the slit lamp and you are going to examine him. If you find any grayish, cloudinish patches that are found on the cornea, that is basically giving you the definitive diagnosis of a diffuse kind of, or even a punctate kind of keratitis. So these are the findings that you're going to look for on the examination when you are looking at the patient on a slit lamp. The causes for the superficial punctate keratitis can be We can have the viral infections. So a lot of viral infections, for example, the herpes simplex virus, we have the herpes zoster virus, the epidemic keratoconjunctivitis, as well as the pharyngoconjunctivitis. So these are the typical viral infections that can result ultimately in a superficial punctate kind of keratitis in the patients. Then we can have the trophic lesions. Trophic was the word, or trophic is the terminology that is used for any lesions that occur at the cornea and that are caused due to damage in the Gausserian ganglion. So if the Gausserian ganglion is pressurized by a tumor, or it has any latent infections, for example, the herpes zoster virus is sometimes infecting this ganglion, then these trophic ulcerations or these trophic lesions can occur at the corneal margins. Now, as well as we can have the exposure keratitis over here that can sometimes result in this kind of superficial kind of punctate keratitis. Toxic lesions, now what are the toxicities that the surface of the cornea is exposed to? It's usually the staphylococcal infections that are infecting or that are basically causing the toxic lesions at the corneal level. And then finally, we have the chlamydial infections. For example, the trachoma inclusions are one of the notorious infections over here, and that usually present with these KP spots or these punctate kind of keratitises. The clinical features would be quite similar, resembling any sort of other keratitis. The cloudiness of the cornea is resulting in the decrease in the visual acuity, whatever the causes. Obviously, the definitive diagnosis is made when you exclude these viral infections or these systemic infections by carrying out the initial investigations in the patient. For example, carrying out the baseline investigations, that is the blood CP, the ESRs are carried out, and that would rule out what are the specific systemic infections that the patient is suffering from. Cultures can be done, and that would again clarify the situation more overly. The causes of the superficial punctate keratitis also include the allergic and the irritative lesions, a lot of allergies, a lot of irritations that are basically present in the environment of the patient can even result in this superficial punctate keratitis in the patient. The specific type of idiopathic superficial punctate keratitis, in which obviously the etiology is unknown, but the features would be quite similar to any kind of other infective states keratitises. The disorders of the skin and the mucous membrane may also be noted down. And you would note down what are the peculiar features of the skin infections over here. For example, if it's a viral infection, for instance, if it's the herpes zoster ophthalmicus, that is basically when the latent virus that is residing in the Gausserian ganglion is reactivated in the older individuals or in individuals who are immunosuppressed, there would be the appearance of these special features, which in a layman terminology is known as shingles. Now, the causative factor for these shingles is the reactivation and the regeneration of the herpes zoster virus in these patients. You would examine the skin lesions in these patients and you would note down the features of these skin lesions in detail. And obviously the mucous membranes have also to be noted down, and what are the positive findings or what are the positive features over here, they have to be documented in detail. Dry eye syndrome, or which is also known as xerophthalmia, should also be taken into account, and it's one of the most important causes. Photoophthalmia. So what is this condition? And it's quite interesting just to know the facts that there are a lot of multiple erosions that can occur at the epithelial level of the cornea just by the exposure of the corneal epithelium to the ultraviolet rays. For example, people who are working in the welding industries or who are working in the cinemas are more exposed to these ultraviolet rays, and that's why they should use these special glasses which are known as the Crooker's glasses, for their normal day-to-day work. So this is one of the important feature over here that can result in this diffuse kind of superficial keratitis over here. So knowing this condition, we'll be discussing this condition, of course, in detail later on. So what are the morphological types of superficial punctate keratitis? So when you look at the findings of these punctate keratitis, you should know what are the features you should be looking for. First of all, you would be looking for the punctate appearance at the corneal epithelium. So the appearance of these spots that you can observe and you can appreciate over here is basically relating to this word punctate over here, and that would basically feature that we have a corneal infection, and that is resulting in the appearance of these KP spots. Then we can have a punctate subepithelial keratitis. So it can be depending upon the situation, if the level or the extent of the damage is including the subepithelial level, then it is basically going to be related to the punctate subepithelial keratitis. So knowing these terminologies and how to interlink these terminologies is again very important. The punctate combined epithelial and subepithelial keratitises, they can also occur in patients who are immunocompromised, of course. And then we have these filamentary kind of keratitis. These filamentary keratitis states are basically the tags of the epithelium that are resulting due to the healing process of the cornea. So that basically shows that there were some sorts of corneal erosions, and these infectious states, they basically resulting in some sorts of erosions at the level of the cornea, and finally the development of these tags of epithelium at the cornea. So this would be regarded as the filamentary keratitis in the patients. It can occur in viral infections, in chlamydial infections, or any chronic infections that the patient is suffering from. The clinical features over here would consist of an acute pain, as you can see that basically it's involving the cornea. So that is basically going to regard as an acute pain. The patient would give you the history of this acute pain. If it's a dull pain, then you're going to basically observe the nature of pain in these patients. The chronicity of the pain as well as the nature of pain is very important over here. As well as we are going to see that the patients are also suffering from photophobia. Excessive lacrimation is noted down in these individuals, as well as sometimes the conjunctiva is also included in these infectious states. So sometimes it's a condition which is known as a keratoconjunctivitis, including the cornea and as well as the conjunctiva. So this would be a complete picture as you would see in a patient. The treatments, of course, would consist of instilling of the artificial tears. So the lubrication again is very important. Xerophthalmia is a condition that the patient can be subjected to, and that is again going to make the patient more prone to the development of these conditions of corneal ulcerations or corneal infections. So just to stop that predisposing factor, you're going to ask the patient to start using these artificial tears. As well as you are going to prescribe the patient of topical steroidal drugs. And of course, we are also going to instill with the antiviral drugs. So this is a prophylactic treatment if the patient is suffering from any viral infections or the chlamydial infections. It would depend upon the predisposing factor and the predisposing condition that the patient has. And according to that, we're going to alter the kind of treatment that we're going to prescribe in a patient. Discussing the condition which was known as photoophthalmia, I've already explained the condition as the development of multiple erosions at the epithelial level of the cornea due to the excessive exposure to the ultraviolet rays. So there are different definitive causes towards the development of this condition, which is known as photoophthalmia. The exposure to bright light of a short circuit, that is basically whenever there is a welding condition, this kind of scenario occurs. Then we have a naked arc light exposure, which is also occurring along with the welding phenomena. And then obviously we have the snow blindness due to the reflected ultraviolet rays. So these are some of the conditions that causes erosions at the corneal level, and that is basically going to affect the visual acuity of the individuals. The patients would usually present to you in the outpatient departments with severe and extreme pain, blepharospasm, and when you're going to examine or when you're going to take the history from these patients, all of these or even one of these predisposing factors can be present in a particular patient. The pathogenesis of photoophthalmia, it basically includes a 4 to 5 hours exposure to the ultraviolet rays, and that basically results in the desquamation of the corneal epithelium in these patients. And then finally, the formation of the multiple epithelial erosions in these patients. So this is basically the final pathological processes that are occurring in a patient who is suffering from photoophthalmia. The typical history would be the exposure to all of those ultraviolet rays, and the clinical features would basically consist of lacrimation, that is basically excessive lacrimation. The patient would give you a history of photophobia and pain and blepharospasm. So the pain would be an extreme kind of pain that the patient is suffering from, as well as there would be a palpebral conjunctival swelling that would be observed in the patient. Retrotarsal folds have to be examined in these patients, and you're going to invert the lids to examine these retrotarsal folds in the patient. The exposure to the ultraviolet rays is again very important over here, and you're going to see for any points in the history that are basically indicating any kind of exposure to the ultraviolet rays. The prophylaxis and treatment that you would give to such patients would be the use of the Crooker's glass. So if there is a patient who is suffering from this condition or who is basically predisposed to this condition, you would ask the patient to use these kind of glasses, which are made of this kind of a special material which is used to protect the cornea. And that basically cuts off all the infrared and the ultraviolet rays. So this is the function of the Crooker's glass. The treatment, if this condition has occurred in a patient, you would give a single dose of tranquilizer, patching with antibiotic ointment to basically predispose the patient to any superimposed bacterial infections in these patients. The cold compresses are suggestive over here, and you're also going to prescribe the oral analgesics in the patient. And we have a condition which is known as the superior limbic keratoconjunctivitis. So as the name is indicated, it is basically a kind of an infectious state that is occurring at the limbus. Limbus is basically the junctional point of the cornea with the conjunctiva. So if there is any sort of infections that occurs at this limbus, that would be regarded as the superior limbic keratoconjunctivitis. So this is a diagrammatic representation of the condition. As you can see over here, the limbus is involved, and as well as the conjunctiva is involved, which can be examined if you invert the eyelid and you examine the bulbar part or the palpebral part of the conjunctiva. You would look that there are signs of congestion, and there are these folds that are observed on the palpebral part of the conjunctiva. And this is a real-life picture from a patient, again showing the superior limbic keratoconjunctivitis, and again emphasizing on the fact you're going to observe that the limbus is involved over here. Of course, it's the involvement of the cornea over here, and even the bulbar and the palpebral part of the conjunctiva is also involved in these patients. The etiology for the development of this condition is it's usually seen in patients with hyperthyroidism, that is, an elevated thyroid hormones levels are making the person more prone to the development of this kind of a keratoconjunctivitis. It is more common in females. The symptoms would be the bilateral ocular irritation that you would observe in these patients, and then of course there would be a mild photophobia that is observed. When you are taking a detailed history from the patient, you're going to look for these symptomatologies. The bulbar conjunctiva has slight features of congestion and irritation that are observed, as you can see even in this patient, and appreciate that. So these signs of infections of the cornea and the conjunctiva would make you suspicious of the fact that this patient is suffering from a sort of a condition which is basically making the patient more prone to the development of this condition. Either he or she is suffering from the elevated thyroid hormone levels, so you would go for these preferable investigations in these patients. The signs would be when you'd be looking or examining the patient by yourself, you'd look for any signs of congestion, and superior limbic or bulbar and the tarsal conjunctivas are also examined in these patients. The punctate keratitis, which stains with fluorescein, and even a stain which is known as rose Bengal, is used for these patients. Then we have the corneal filaments that are involved in the particular area which is infected. So these are basically the particular signs or even the investigations that you would carry out for these patients who are suffering from this kind of a limbic keratoconjunctivitis. The treatment over here would consist of the artificial tears that you would give as a lubricant. The topical corticosteroids would also be quite frequently used for these patients. And then, of course, the faint diathermy of the superior bulbar conjunctiva can be used as a surgical treatment in these patients. The therapeutic soft contact lenses are used just as a protective factor in these patients. Recessions and resections are also covered up. Now, why are these recessions and resections done for these patients? Sometimes there is, along with the hyperthyroidism, these patients are suffering from proptosis, which is making a condition which is known as exposure keratitis in these patients more common. And sometimes even the conjunctiva is involved due to this factor, which is of the proptosis. So this is the basic pathology over here. So to treat that pathology, we are going to give these recessions and resections. These are surgical procedures to correct the exposure of the conjunctiva and the cornea. That is basically approximating the lateral tarsorrhaphes. So over here, you can perform these surgical procedures even in these patients. We have another variant over here, which is known as the Thygesson's superficial punctate keratitis. The etiology over here is usually viral. It can be allergic or the dyskeratotic nature. So this is the kind of nature or the kind of etiologies over here that you're going to see. The clinical features, it basically involves all the ages. It is bilateral in origin, and it's usually a chronic disease. It may be asymptomatic and is usually associated with photophobia. The signs in this Thygesson's variety are the corneal lesions that you would observe, and then finally you're going to look for the coarse lesions, that is the snowflake appearance of the cornea. So this is again a very characteristic finding. As you can appreciate over here in this diagram, these are the snowflake appearances, as you can observe in this kind of cornea, that the patient is suffering from Thygesson's kind of superficial keratitis. And then no conjunctivitis. So usually this kind of Thygesson's punctate keratitis is not associated with any sort of conjunctivitis in these patients. The treatment for this sort is the disease is usually self-limiting with remissions. And usually the topical steroids, they are going to be used whenever the condition is exacerbated or there is an acute episode in the patient. The use of the therapeutic soft contact lenses are used just as a bandage aid is used in these patients. Then we have the filamentary keratitis. The word filamentary is basically suggestive of the fact that there are epithelial tags in this kind of corneal inflammatory condition. The characteristics over here are, first of all, the pathogenesis of this filamentary keratitis would be whenever there are epithelial erosions due to any cause. For example, it's an infective cause or any chlamydial infections, viral infections, or any trauma. And there is this healing process That is going to finally result in these epithelial tags and giving away the final appearance of the filamentary keratitis in these patients. They are basically due to the focal epithelial erosions. These symptoms would usually consist of irritation, lacrimation, and a foreign body sensation in these patients. And the signs that you would look for are the filaments, of course, on the slit lamp examination, and the superficial punctate keratitis in these patients are also noted down. The causative factors would be the KCS. So it's one of the conditions that is the keratoconjunctivitis sicca, or it's also known as the dry eye syndrome. So it's one of the predisposing factors towards the development of the filamentary keratitis. As well as it can be an idiopathic origin, and then we have the development of this kind of keratitis due to the epitheliopathy. So it can be the epithelium of at any level. The epithelium of the conjunctiva is sometimes involved, or even the epithelium of the cornea is involved. Then we have the epithelial erosions of any other sort, for example, the toxic epithelial erosions, or it can be the systemic disorders, or either it can be the patching of the eye resulting in this sort of filamentary conditions at the level of the cornea. The treatment would consist of a mechanical debridement of the filaments. That is one of the treatment of choice, and you would also ask the patient for the use of therapeutic soft contact lenses. The treatment of the underlying cause is very basic over here. Whatever the underlying cause is, either it's the infection, or either it's the exposure to the ultraviolet rays or the photoophthalmia, you have to treat the underlying cause first of all. The deep keratitis is one of the variety. It can be caused by the congenital and the acquired syphilis. We have the tryponomiasis, or on the other hand, we have the Cogan's syndrome, in which basically the patient ultimately suffers from visual disturbances and deafness as well. We have tuberculosis, which can also result in the deep sorts of keratitis. And finally, we have the patients of leprosy, who are also resulting, or who are also ultimately ending up with this deep keratitis in the patients. So we have patients of malaria, and finally we have patients of sarcoidosis. So these are some of the systemic infections that can basically lower down the immunity of the individual. The treatment itself, or the disease itself, is making the patient more prone to the development of this deep inflammations or deep infections of the cornea. We have the syphilitic interstitial keratitis, which is also termed as the lutic keratitis in the patients. So this is one of the condition that is caused due to this organism, which is known as the Treponema pallidum, and the patient is basically suffering from the syphilis. The pathogenesis would be the manifestation of the local antigen-antibody reaction in the body. The Treponema pallidum invades the cornea. The sensitization of the corneal inflammation ensues, and that is basically triggering the injury of the corneal epithelium as well as the eye operation. So this is the complete pathological process behind this condition. The clinical features over here would be the initial progressive stage that is characterized by the KP spots and the ground glass appearance. So it would be an appearance that is appreciated moreover on the slit lamp examination. Then we have a complete florid stage, which is characterized by the deep vascularization and the salmon patch appearance. The stage of regression is sometimes noted down, which is characterized by the ghost vessels, and the clearing of the cornea is also quite slow in this regressive stage over here. How will you make the diagnosis in these patients? The positive VDRLs and the Treponema pallidum immobilization test. These are the diagnostic tests for the isolation of the organism. Once you have diagnosed the case, you're going to make a treatment plan for these patients. The local treatment plan would consist of the topical corticosteroid drops that you would use for these patients. Now, again, it's very important to use these drops with care because sometimes it's going to even aggravate the situation or even make the person more prone to the development of superimposed bacterial infections. You can also start instilling the cycloplegic drugs. The most notorious of these drugs is the atropine eye ointment that you would ask the patient, and the dark goggles for the photophobia are used, and these are basically the conventional steps that you would take for any sort of keratitis and that you're also taking over here for this syphilitic kind of keratitis. You would observe that you are going to basically specifically enhance the history taking. Then you're going to perform, if you're to suspect that this patient might be suffering from syphilis, you're going to perform those cultures as well as the isolation of the organism, that is the Treponema pallidum, is again very important over here. And then finally, you can also plan for some sort of surgeries. For example, surgeries like keratoplasties are also planned for these patients when dense opacities are left and the visual acuity is quite decreased in these patients. The systemic treatment for the syphilitic interstitial keratitis would include the penicillins in high doses for these patients, and then of course you're going to use the systemic steroids in the refractory cases that are not responding to the typical, or those are not responding to the specific kind of topical treatment. The other infections that can result in keratitis are the tuberculous interstitial keratitis. It's usually unilateral and sectorial in origin. Anti-tubercular drugs, the patient is usually a diagnosed case and he's already on a regimen of the anti-tubercular drugs. Topical steroids can be used, and you're also going to prescribe the patient of the cycloplegic drugs that are given for these patients. Then, of course, there are other syndromic conditions. Now, this Cogan's syndrome is again very important over here. As I've already told you, that in this syndrome, the patient suffers from mild deafness, as well as he or she is suffering from some sort of or some level of visual loss is also noted down in these individuals. There is a Hutchinson's triad that is noted down in these individuals with Hutchinson's teeth, and that is also noted down in the vestibular deafness as well as the interstitial keratitis. This Hutchinson's triad is also a part and parcel of the interstitial keratitis or the deep keratitis that we have studied before, and Cogan's syndrome is one of the variant of the deep keratitis. So you can also see over here that the patient is also suffering from a vestibular kind of deafness even over here. The occurrence is usually in the middle-aged adults, and often it is a bilateral condition. The features that are quite typical over here are the interstitial keratitis of an unknown etiology, as well as the patient would give you the history of acute tinnitus, vertigo, and even deafness. Once diagnosed with this condition, which is known as Cogan syndrome, the treatment that you would give for these patients are the topical and the systemic corticosteroids that you would be using for these patients. So basically, in this lecture, we summarized the different conditions that basically can result in the superficial keratitis. That is sometimes not coupled up with the development of the ulcerations, as well as we have other miscellaneous conditions, or we have other miscellaneous syndromic conditions in which the patient suffers from the deep sorts of keratitis conditions, as well as the visual acuity is decreased in these individuals. If these conditions are not treated properly, even after diagnosis, you haven't had the management plan that is appropriate for these particular conditions, these patients can even result in the loss of vision. So again, it's very important, and again, it's very crucial to make a proper treatment plan for these patients. So that is the end to this lecture. Thank you for watching sqadia.com.